Thank you. Sorry for the interruption. So then we are going to do for the target organ damages. As I've told you, that these are, and then you have got much rarer but serious complications like eclampsia 4.5%, aortic dissection, typhoid B 2%, renal retinal hemorrhage exudate, that is 0.01 to 02%, and then retinal hemorrhage and exudate. And you can also have something indirect, evidences of organ failure associated with health syndrome like liver enzyme elevation. Acute kidney injury is common, is about 10%. So these are the basic ideas. So you can understand the main brunt is on the CNS and the circulatory system, including the heart and the kidneys. So these are the things which are mostly damaged in the target organ damage group. So clinical and laboratory workup, clinical evaluation, a detailed history including duration of hypertension, associated symptoms and other diseases. One of the commonest cause of this hypertensive emergency is the patient not sticking to their usual hypertension regime, antihypertensive regime. So you should be taking a careful history of what drugs they are taking and what drugs they have discontinued, particularly beta blockers and clonidine drugs, which when discontinued may give rise to rebound hypertension and hypertensive emergencies. Next, drug history including over-the-counter drugs, and people they pop drugs and they can be playing some effect on with the hypertension. You can have even health supplements with stimulants which taken in large amount might be putting the patient into a hypertensive emergency. Some drugs may give, they need extra precaution, particularly patients who are on drugs like tardanafil or sildenafil. You need to be careful because when they are given a nitroglycerin infusion for a treatment of accelerated hypertension, they might have paradoxical increase in blood pressure. So take a detailed history, and also you should be taking a history of substance abuse. Particularly cocaine has been implicated in giving rise to hypertensive emergencies. So you should be taking that history. And some drug interactions, monoamine oxidase inhibitors with amphetamine, tricyclic antidepressant. So these are again combinations which might give rise to such emergencies. Next, in females you should also take the history of last menstrual period. Symptoms related to target organ disease like chest pain, back pain for aortic dissection, focal neurological signs in cerebrovascular accidents, oliguria, visual disturbances, etc. And detailed clinical examination needs to be done. Blood pressure measurement has to be done in both arms. Some people might be having arthritis and not reflecting the exact blood pressure in one of the arms. And people with aortic dissection might be there is a difference in the two arms, and that might alert you that this patient might be having something like that. So look for murmurs, look for abdominal bruise, get an ophthalmos to be done. I told you if there is a group like a malignant hypertension, they might be having a worse prognosis and neurological evaluation. So these are the basic things you do in a clinical examination. This is the typical papilledema. You can see that the discs have been blurred, margins are blurred, and that you should be able to pick up. Also the hemorrhages you need to pick up. Diagnostic workup in a patient with suspected hypertensive emergency. Common tests for all potential causes. Fundoscopy is critical, I told you. Then 12-lead ECG, hemoglobin, platelet count, fibrinogen. I told you some of these patients will have rarely everything like a DIC-like syndrome. Then creatinine, EGFR electrolytes, LDH and haptoglobin. Urinary albumin creatinine ratio. Urine microscopic for red cell, leukocyte cast, etc. And pregnancy test in women of childbearing age. That's of course. Next, specific test by indications for this acute coronary syndromes, already discussed in detail by Pradeep. Troponin, CKMB, in case of acute chest pain or acute heart failure, and the NT-proBNP if you're in doubt. Chest X-ray for fluid overload, echocardiogram. You will also pick up your aortic dissection, at least the type A. CT angiograph of thorax and abdomen in suspected acute aortic disease, aortic dissection, that is necessary. So sometimes you might be going, if you're in a diagnostic dilemma, you might be doing a CT angio with a CT coronary angio and pick up what is the cause. CT or MRI brain in case of nervous system involvements. Renal ultrasound for renal impairment or suspected renal artery stenosis. And urine drug screen if you suspect there has been a drug abuse or substance abuse. Now you go for the general treatment. So any elevation in BP that makes it a hypertensive crisis. You suddenly find a patient who is uncomfortable and you have got a very high blood pressure. I told you cutoffs. Cutoffs they slightly vary in some guidelines like 180, 120 or 180 by 110. Some people say it should be 200, whatever it is, but accepted thing is 180 by 120. sign, and then to see whether there are signs of end organ dysfunction. I have already listed the common ones. If there are no end organ dysfunctions, it's an hypertensive urgency, and they are rather treated in more conservative way, and some people can be even let go for an outdoor follow-up. And if there are signs of end organ dysfunction, then it becomes a hypertensive emergency. Next, you will have to have a general treatment goal, that if you find, and there are some things, these are called compelling cases, where there need to be separate guidelines. We'll discuss this, what is general treatment goal, and these people with aortic dissection or a stroke or a pre-eclampsia and eclampsia, they will have slightly different goals than this general hypertensive emergency objectives. So these are the general treatment goals for hypertensive emergency, that is excluding the aortic dissection, this pre-eclampsia, eclampsia, and strokes. First hour, reduce the mean arterial pressure by 25%. The idea is that people always know that it was pointed out much earlier in the 90s that if you reduce the blood pressure very rapidly, they may actually do some harm. There might be some problem with the perfusion. There are a thing called that they have a thing called they've got a reset sort of their hypertension feedback loop. People who are chronically hypertensive, and they might be reacting differently to sudden drop in blood pressure with poor perfusion, precipitating cardiac or renal complications and even worsening strokes. So that is to be avoided. Reduce AFP by 25% while maintaining a goal of diastolic blood pressure more than 100. Don't reduce the diastolic blood pressure initially less than 100. Hours 2 to 6, systolic blood pressure target should be about 160 and diastolic from 100 to 110. That is the next 2 to 6 hours. From 6th hour to 24th hour, maintain the goal of hours 2 to 6 during the first. This should be maintained for first 24 hours. And then after that, from 24 to 48 hours, you go on to trying to achieve what was the target goal in a normal patient, OPD patient, like if you want to have a less than blood pressure, less than 140/90, you target that. Go by the 2017 guidelines. So that is the general purpose, that if you don't have these special cases, this is the goal what you need to do. Do not try to reduce the blood pressure too early. Next, there will be some special cases which will be going after we discuss the drugs. Those we'll be discussing after that. So what are the drugs we use in hypertensive emergencies? As they are emergencies, and I've told you that you need a specific level of control, not too high, not too much of control, but then rapid enough control. So preferred drugs are all intravenous. Only a few of these intravenous drugs are available right now in our country, so many of them are not, but I'll discuss these drugs. So you can see this is a list, like these are the IV calcium channel blockers. I don't think they're available right now. Nicardipine, initial dose is 5 mg per hour and increase every 5 minutes by 2.5 mg to maximum 15 mg per hour. This is contraindicated in advanced aortic stenosis. No dose adjustment is needed for the elderly. This is otherwise a very safe drug. It is right now. It has been shown to be basically working faster than IV beta blockers. Labetalol, which remains the standard therapy in most of the cases of acute accelerated hypertension, they work faster than that, labetalol, and better control of blood pressure. A new drug has come. It is even more specific and shorter acting than nicardipine, and this is called clebidipine. Initial 1 to 2 mg per hour, doubling every 90 seconds until BP approaches target, then increasing by double every 5 to 10 minutes, maximum dose of 33 mg per hour and maximum duration of 72 hours. So this is the drug. There is one problem, it is put in a lipid solution. So people with soybean, soy product or egg allergies, they should not be given these drugs. And it has got a sort of calorie value that if you go on giving it every hour, there is an added calorie with this. So you should be careful about that. But it is more shorter acting and more specific than nicardipine. Then you have got direct vasodilators, of which nitroprusside remains a preferential arterial dilator and nitroglycerin remains a veno-arterial, mostly a venodilator. So nitroprusside, it should be given with the special precautions of protecting it from the light, and initial 0.3 to 0.5 microgram per kg per minute, increase the increments of 0.5 microgram per kg per minute to achieve BP target. Maximum dose is 10 microgram per kg per minute. Duration of treatment is as short as possible. Because basically they have got a thing called a cyanide toxicity. Once you give nitroprusside for long, the patient might be having headache, vomiting, nausea, etc., which might be signs of cyanide toxicity. Another problem is that they causes stilts. They act, I mean, it is a very strong arterial dilator, and at random they dilate the arteries, so they might causing a coronary stenting. Basically, they dilate all the arteries, coronary arteries. So the healthy arteries, they dilate far more than the diseased arteries. So ultimately happens the blood flows more in the healthy arteries and the blood flows much less in the diseased arteries, which worsen the coronary artery disease, acute coronary disease. Similar things might happen in strokes. So you should be careful in using sodium nitroprusside in situations where you feel there might be stills. And nitroglycerin, the thing is that it is mostly a vasodilator. Initial dose is 5 microgram per kg minute. Increase the increments of 5 microgram minute per every 3 to 5 minutes to a maximum of 20 microgram per minute. So that is the dose. Only thing is that, as I have told you, that it is a preferential vasodilator. If you somehow feel that this patient might be volume depleted, typical example of hypertensive emergency with a volume depletion are preeclampsia, eclampsia. When there is less intravascular volume, yet the patient is hypertensive. So in that cases, if you use a nitroglycerin, there might be a precipitous drop in blood pressure. So be careful about using in those patients. This there is a thing which is not very preferred drug nowadays, hydrolazine intravenous. This is mostly used still by the gynecologists in the this pre-eclampsia, eclampsia cases. Initial 10 milligram via slow IV infusion, and then repeat every 4 to 6 hours is needed. In long range, some of these drugs might be longer use, they might give rise to SLA-like syndromes, and they also give rise to extra nausea and vomiting in the patients. Then you have got adrenergic blockers, of which beta-1 selective antagonist. The shortest and the most specific is the esmolol, loading dose of 500 to 1000 microgram per kg per minute over 1 minute, followed by 50 microgram per kg per minute infusion. For additional dosing, the bolus dose is repeated and the infusion increased in 50 microgram per kg per minute in 3 minutes. The thing is that the beauty of the drug is that it is a very short acting drug. Even if the patient goes into a shock, anything, or bradycardia, whatever, you stop the drug and instantly, in few minutes, the effect goes. Contraindicated in patients with concurrent beta blocker therapy, so you cannot use a double beta blocker. Bradycardia, in case of acute decompensated heart failure, if you feel the patient has gone into a bad pulmonary edema, then it is not a preferred drug. Monitor for bradycardia may worsen heart failure. Higher doses may block beta 2 receptors and impact lung function. So that is all beta blockers, that is the problem. Next, this is a very preferred drug. This is a labetalol. The advantage is that it is both beta and alpha blocker, and initial 0.3 to 1 milligram per kg dose, maximum 20 milligrams slow IV injection. It can be repeated and it can be given in repeated IV injections, or it can be given as an infusion up to 3 milligram per kg per hour. The maximum dose given is 300 milligram. So that is a very preferred drug. Remember, with beta blockers, if you are using particularly patient where you suspect there might be pheochromocytoma, if you use preferential beta blockers, then the alpha activity takes over and the patient may have a paradoxical rise in blood pressure. So that is, you should use an alpha and a beta blocker together. That's very important in cases of pheochromocytoma. Next, this is a phentolamine. This is non-selective alpha receptor antagonist. This is used in IV bolus, dose 5 milligram, additional bolus dose every 10 minutes, addresses to lower BP to target. Used in hypertensive emergency induced by catecholamine excess. Typical example is pheochromocytoma. That's what I said, that you will have to block the alpha first in case of pheochromocytoma patients. And then you have got a drug called a newer drug, phenol-dopamine. This is a dopamine 1 receptor selective agonist. This is given in 0.1 to 0.3 microgram per kg per minute, and this is contraindicated in patients at risk for increased intraocular pressure, glaucoma, or intracranial pressure in those with the sulfite allergy. So this is not a preferred drug in case of CVS. And then you have got an enalaprelate. This is an injection given given once every twice daily or thrice daily, and initial 1.25 milligram over a 5-minute period, and they can be increased up to 5 milligram every 6 hours. This is not preferred in pregnancy. Basically, this is a standard teaching that if you have got a pregnant patient with a hypertension, you are not supposed to use diuretics and ACE ARBs. That is there. And it is useful in hypertensive emergency with high plasma renin activity. They are also not preferred drugs in cerebrovascular accidents. One problem with drug is that it is a very long-acting drug. So once you are given, and if the patient after that goes into some hypertension, it might give rise to added problems. So these are the specific areas where some of these drugs are used. Hydrolazine is typical indication right now is pregnancy. Still it is used in as hypertension. Can result in prolonged hypertension, given longer high life, risk of reflex tachycardia, if not given along with a beta blocker, headache, lupus-like syndrome. Nitroglycerin, coronary ischemia or infarction is specific, where you prefer this drug. Acute left ventricular failure, pulmonary edema. There is a thing called a tachyphylaxis, particularly in the first 2 days. The body gets used to this drug and the effect goes down rapidly. So first 2 days it might be that the patient you are requiring more and more dose of nitroglycerin and to control, keep the same blood pressure level. So that might be a problem. And as I've told you, if the patient is volume depleted, be careful about using a vasodilator. Sodium nitroprusside, most indication excluding increased ICP and coronary infarction ischemia. Where you feel there might be still, do not use a nitroprusside. If the patient has got aortic dissection, use a beta blocker first and then this sort of drugs. We'll discuss that when we discuss that syndrome. It might be troublesome in liver failure, renal failure patients because of cyanide and thiocyanide accumulation, and you can try cyanide and thiocyanide concentration. Toxicity is associated with prolonged infusion. So it is not recommended for more than 3 days at a stretch or very high doses. May result in coronary ischemia or increased ICP. Clevetin, as I have told you, acute ischemia or hemorrhagic stroke, formulated in oil and water formulation, providing 2 calories per milliliter of lipid calories. So that is very important. And caution for patients with soil irregularity, risk of reflex tachycardia. Nicarditis, acute ischemic or hemorrhagic stroke, risk of reflex tachycardia, infusion can be to large volumes administered. Escolol, typical indication is aortic dissection and coronary ischemia infarction. Contraindicated in acute decompensated heart failure, particularly if the patient is in pulmonary edema, should be used in conjunction with arterial vasodilator for BP management aortic dissections. So basically the first drug in aortic dissection, we'll discuss that when you go into aortic dissection. Metabolism is organ independent, hydrolyzed by esterase in blood, and so there is no problem if you use in advanced renal failure patients. Labetalol, acute ischemic or hemorrhagic stroke, aortic dissection, coronary ischemia infarction, pregnancy. In all these cases, this might be a preferred drug. May be used as a monotherapy in acute aortic dissection, contraindicated in acute decompensated heart failure or bradyarrhythmias. Prolonged hypertension may occur with overtreatment, dose cautiously. So it remains in the blood for quite some time, though it's given as an infusion. And metoprolol is another injectable beta blocker, but it is not normally given as an infusion, it's given as repeated bolus dose. Again, the problem is that the effect remains for about 4 to 6 hours, sometimes 12 hours. So you should be careful in giving a patient with an unstable blood pressure. Contraindicated in heart failure, and it should be used in conjunction with an arterial vasodilator for BP management in aortic dissection. Useful in tachyarrhythmias. Enalaprilate, acute left ventricular failure is the indication, contraindicated in pregnancy, cautions of dosing, prolonged duration of action. It's also not preferred drug in cerebrovascular accidents. Phentolamine, catecholamine excess like fibrinocytoma, phenoldopam, most indications it can be used. And it can cause hypokalemia, flushing can worsen, glaucoma, and there might be a peripheral vasodilation because of this MOAD2 specific agonist. Now some specific situations. I told you there are some compelling things where you don't go by the normal cutoff of that. I told you that 25% reduction in first 1 hour and then below 160 to 100, 110 in next 2 to 6 hours. This is the general standard formula. We don't follow this. This is one thing is aortic dissection. If you remember, the aortic dissection is basically, there are 3 types. When there is the involvement of the aortic root, ascending aorta with the descending aorta, and there is only the ascending aorta and only descending aorta. This was initially classified by DBT as type 1, type 2 and type 3. Now they have been classified, these two together are type A. That whenever there is an involvement of the ascending aorta, whatever it is, how long it is maybe, it is a type A. And if there is no involvement of the ascending aorta, then it is a type B. This A is a surgical emergency. Basically what is happening, you can see that this is rapidly progressing to involve the aortic valve and the patient will progress into acute aortic regurgitation. That's the main risk, and you need to correct that surgically. So drugs, they do come, but preferable thing is this patient should be made ready for early surgery. The role of drug therapy in stabilizing the patient is mostly the type B. That too in stable type D, that where you do not have renal artery involvement, you do not have rapidly progressing this dissection. In those cases, again, there are surgical emergencies. Here, that you need to go for a medical therapy for some time and try to stabilize the patient. So, first drug is always an venous beta blocker. That's very important in aortic dissection. You do not control the blood pressure without simultaneously controlling the heart rate. because aortic dissection is worsened by both rising heart rate and rising blood pressure. So that is both are important. So you do not give any vasodilator immediately in aortic dissection unless you have already controlled the heart rate. So first is the intravenous beta blocking agent, and then lower the systolic pressure to 100 to 120 millimeter mercury, but aortic regurgitation should be excluded. Other agents may be useful in achieving target. I have told you that once you got the beta blocker and you feel that the blood pressure control is not adequate, you can go for vasodilators like nitroprusside. Hypertensive emergencies in pregnancy. So there are several types. One might be commonest is preeclampsia, where the systolic blood pressure is more than 140, diastolic more than 90. With that, you may have, these are not essential right now, but you may have proteinuria and other features like peripheral edema, etc. Then this preeclampsia might be proceeding to eclampsia, where there are basically neurological involvement with seizures, and there might be some of this HELP syndrome, that is hemolysis, elevated liver enzymes, and low platelet. Mind you, all HELP syndromes do not come with a blood pressure elevation. Basically, there is an overlap between the syndrome between this HELP and preeclampsia, and some of them will come with hypertension or they may not. And then you can have a hypertensive emergencies in pregnancy where the blood pressure is greater than 240 to 140, and severe acute hypertension, systolic blood pressure greater than 160, diastolic more than 110. The drugs we have already discussed, basically two drugs are preferred right now. One is the preferred drug right now is basically labetalol in pregnancy, this preeclampsia and eclampsia. But some people also prefer hydrolazine in this injectable hydrolazine in this patient. You can also use, but do not use ARBs, enalaprilate, diuretics in this patients. That is contraindicated. Coronary artery disease. Recommendation is that here the target is slightly less. If it is an acute coronary syndrome, including STEMI or a non-STEMI or a severe hospital angina, target systolic blood pressure is less than 130 if tolerated, but not less than 120. So you should not reduce because the perfusion of the heart may be at stake. So they are an older patient greater than 65 years to target systolic blood pressure 130 to 140, and diastolic blood pressure to less than 80 but not less than 70. So that's also very important. So keep and watch on that there should be too much of a drop in blood pressure. Hypertensive patients with a history of mitral infarction, beta blockers and RAS blockers are recommended as a part of treatment. In patients with symptomatic angina, beta blockers and calcium channel blockers are recommended in the acute stage. These are the preferred drugs, and of course we can use intravenous. We do use intravenous nitroglycerin. Next is acute heart failure, decompensatory heart failure. In hypertensive patients with heart failure or reduced or preserved ejection fraction. Now you know that heart failure, almost 50-50 of the heart failure, echo ejection fraction is no more a diagnostic tool for heart failure. They are used mostly to pick up which treatment you are going to give, but not to diagnose heart failure. So many patients will be 50% of the patients with heart failure will have a normal ejection fraction. So these are called what is called in heart failure with a preserved ejection fraction or preserved systolic function. These are the groups, and there might be a group with a heart failure with reduced ejection fraction. So this, and now we have got a third group with marginally reduced ejection fraction. Anyway, so these are the two groups. In hypertensive patients with heart failure, BP lowering treatment should be considered if BP is more than 140 to 90. In patients with heart failure with reduced ejection fraction, it is recommended that BP lowering treatment comprises of an ACE inhibitor and ARB and a beta blocker and a diuretic. So these are the preferred drugs in case of heart failure patients. In case of heart failure with preserved ejection fraction, no drug has been proven, other than diuretics, no drug has been proven superior to another. So here you can use after that an ACE inhibitor, ARB or a beta blocker depending on your clinical presentation. One thing is that in heart failure, calcium channel blockers, if at all used, can be only this amlodipine group basically. The verapamil and the diltiazem group, the non-dihydropyrimidine group is not preferred in heart failure patients. That is, they are not good drugs. So that is there. Even this calcium channel blockers are not first line. You have used beta blocker, you have used ARB or ACE inhibitor, you have used diuretic. After that, if you feel that the blood pressure is not well controlled, you should be moving on to calcium channel blockers. And the last of this group are the cerebrovascular accidents. There are huge trials done on these groups. Still, we are awaiting a clear-cut answer in what? We know some few things, that basically the intervention to control blood pressure in all cerebrovascular patients are in the acute stage. First 1-2 days or maybe first few hours are very important. After that, after first 2 days, what we target is basically the guidance for a chronic hypertensive patients. That is to prevent the further stroke. For the first stroke, all the interventions needed to control blood pressure is in the first few hours. So unless you have achieved that, you are not achieving anything in cerebrovascular patients, accident patients. In ischemic stroke, we withhold antihypertensive medication unless the systolic blood pressure is above 220 or the diastolic blood pressure is above 120. Do not treat. So unless, of course, you might be having, combos basically, that you have got a ischemic stroke and on top of that you have got a myocardial infarction or a heart failure. That's a different issue. You use those guidelines. But if it is a pure ischemic CVA, do not treat unless the systolic blood pressure is above 220 or the diastolic blood pressure is above 120. Except if you feel that the patient is eligible for IV TPA, you want to go for thrombolysis, then the cutoff value is systolic blood pressure should be less than 185 and diastolic below 110. You need to achieve that immediately so that you can start the thrombolysis. Unless you achieve this control, the thrombolysis is contraindicated. The preferred medications are levetiracetam and nicardipine. But then we'll discuss the drugs after the second slide. And this second group is the acute intracranial hemorrhage. Uncontrolled BP in early course of disease is associated with increase in hemorrhage, unfavorable neurological outcome and mortality. So BP control is beneficial only in the course of the disease. That is what I'm telling you, that is the most important, first few hours or maybe first 2 days. And after that, the BP control becomes only an exercise to contain the next stroke or prevent the next stroke. American Stroke Association and European Stroke Organization recommend intense blood pressure control. Achieve a systolic blood pressure of 140 mm in first hour of time to be safe. This is safe and beneficial if the patient presents within 6 hours. So if the patient is present within 6 hours, go for a rapid control of blood pressure. That helps. And you can go for an intense control, it does not cause any harm to the brain. Intravenous drugs should be used. Levetiracetam and nicardipine are usually used, although there is no evidence to choose one over another. Previously it was thought that you are not supposed to use nitroglycerin, but it has not been proven to be harmful. So you can use other drugs. I told you some drugs they have got contraindication, enalaprilate you are not supposed to use in this. And if you feel there is a chance of steal, do not use nitroprusside. So these are two, otherwise you don't have much choice, you can use any drug. After first few days, the goal of antihypertensive therapy is prevention of recurrent stroke and the target BP becomes much lower. So cutoff is here, basically the cutoff is that you maintain a mean arterial pressure of around 130. That is good enough for you or for hemorrhage. Subarachnoid hemorrhage target systolic blood pressure is 160 mm or less, a bit more liberal. Avoid too much reduction in BP, particularly in impending cerebral vasospasm. So this is, once the patient is going into a vasospasm or impending vasospasm, then you should not reduce the BP further. In fact, if the BP is too low, you need to raise the BP. Nimodipine, which is used to prevent, this is a standard drug which is used in subarachnoid hemorrhage, but this purpose of nimodipine is to prevent cerebral vasospasm. And it is not to be used for acute control of blood pressure. Now, there are 2 or 3 guidelines for this blood pressure controls, blood pressure emergencies. Mostly they are corroborating, they have got similar objectives and similar goals and similar drugs. GNC 7 had a detailed discussion on hypertensive emergencies. GNC 8 does not mention hypertensive emergencies. So they have, apparently the guidelines they have not changed in last 10 years time. And European Society of Hypertension and European Society of Cardiology, they have also got goals. I'll show you the JNC 7, we'll go by that. This is some patients may benefit from treatment with an oral short-acting agent such as captopril, levetiracetam, or chlorine, followed by several hours of observation. These are called urgencies, basically hypertensive urgencies. Both of them they use this term, hypertensive urgency or hypertensive emergency. This is without target organ damage, I told you, and this is with target organ damage. So here you can start off with and treat them mostly as outpatients. There is no evidence to suggest that failure to aggressively lower blood pressure in ED is associated with any increased short-term risk to the patient. So here your goal is not that you need a very urgent control. You can, if the patient is not very symptomatic, you can let the patient go home with a watch on blood pressure or keep in the hospital without critical care and slowly control his or her blood pressure. Here, reduce the mean arterial pressure, as I've already discussed this protocol, and listed parenteral drugs are already there. European Society almost tells the same. Isolated large blood pressure elevations without acute or discomfort should not be considered an emergency, but treated by the institution or intensification of drug therapy and treatment for anxiety. That's also very important. No specific agents mentioned for hypertensive urgency. You are free to use whatever you feel like. And here again, this is almost same as the JNC 7. JNC 8 does not make any recommendation for hypertensive emergency. No fresh recommendations. The same here. And for hypertensive urgencies, routine screening but acute target organ injury, serum creatinine urine analysis is not required. To select patient populations, screening for elevated serum creatinine level may identify kidney injuries that affects disposition. That might make an indication for hospitalization. And routine emergency intervention is not necessary. In select patient populations, emergency physicians may treat markedly elevated blood pressure in the emergency room or discharge the patient and follow up in OPD. So the guidelines are basically similar. I told you only thing is that European guidelines, they are highlighting this malignant hypertension and telling that they have got a worse prognosis. JNC 7 and JNC 8 does not casually mention JNC 7 mentions malignant hypertension but does not care to define it or put any different treatment or prognosis to that. Thank you.
Thank you, sir.
हाँ जी सर निकालना है सर।